Hello friends, welcome to TechQuest channel. This is for the medical technologist by URTech. In this video, we will discuss about uric acid. In humans, uric acid is the major product of the catabolism of purine nucleosides, adenosine and guanosine. Purines from catabolism of dietary nucleic acid are converted to uric acid directly. However, the bulk of purines ultimately excreted as uric acid in the urine originate from degradation of endogenous nucleic acid. The normal excretion of uric acid by the kidneys should eliminate two-thirds of the uric acid from the body daily. The remaining one-third is in the bile and intestinal secretions. The intestinal bacteria act on the secretion by uricolysis and the waste are excreted in feces. The level of uric acid in the blood is maintained by a balance between the amount that is produced and the amount that is excreted. Under normal conditions, a temporary rise in the serum uric acid level can occur after ingestion of foods that are rich in purine, organ meats, ligaments, meat, and some fish, after exercise or heavy alcohol injection or during periods of stress. This type of rise is temporary and the blood level returns to normal within a day. Hyperuricemia, an elevated level of uric acid in the blood, results from excessive production of uric acid or impaired excretion of uric acid or a combination of the two causes. The conditions of abnormal overproduction include the abnormal metabolism of purines and amino acids, excessive catabolism of body tissues, destruction of nucleoproteins, some cancers before and after chemotherapy or radiation, some endocrine and hemolytic disorders, and conditions that cause acidosis or lactic acidosis. Impaired excretion of urate retention is usually due to the renal disease that affects tubular secretion and reabsorption. It may also be caused by reduced renal blood flow and decreased renal filtration of blood. Gout is a genetic disorder of purine metabolism that usually produces a high level of uric acid in the blood and monosodium urate crystal deposits throughout the body. The deposits are located in the joints, cartilage, blood, bursae, and subcutaneous tissue. Some patients, however, develop gout with lower elevations of serum uric acid, and some patients have high levels of serum uric acid and do not acquire this inflammatory disease. The urate crystals can also accumulate in the renal pelvis and cause uric acid kidney stones to form. Severe hyperuricemia, as indicated by serum uric acid levels of 12 milligrams per deciliter or more, can be dangerous because the urate crystals can accumulate in the renal tubules and ureters, resulting in obstruction and renal failure. This crisis can occur when leukemia is treated with cytotoxic drugs or a malignancy is irradiated. Both of these treatments cause lipid necrosis of tissues and excess catabolism of nucleoproteins. Hypouricemia, the abnormally low level of uric acid in the blood, usually results from defects in renal tubular absorption. The disorder can congenital or acquired. There is an increased urinary loss of urate and therefore a low level of uric acid in the blood. The normal values, the reference values for uric acid is for adult male, it's 4.5 to 8 milligrams per dl. For female, it's 2.5 to 6.2 milligrams per deciliter. Children below 12 years old, it's 2 to 5.5 milligrams per dl. Adult above 60 years, male, it's 4.2 to 8 milligrams per dl. For female, it's 2.7 to 6.8 milligrams per dl. Elevated uric acid results are seen in gout, renal failure, polycystic kidney disease, leukemia, lymphoma, toxemia of pregnancy, lead poisoning, psoriasis, tumor lysis syndrome, diabetic ketoacidosis, shock, Down syndrome, glycogen storage disease, hemolytic anemia, polycythemia vera, pernicious anemia. Decreased values are seen in Fanconi syndrome, Hodgkin disease, bronchogenic carcinoma, Wilson disease, multiple myeloma, and xanthinuria. Lab diagnosis of uric acid. Analytical methodology, phosphotungstic acid, uricase, and high performance liquid chromatography methods are used to measure uric acid. Phosphotungstic acid methods are based on the development of a blue tungsten blue as phosphotungstic acid is reduced by urate in alkaline medium. The color is red at 650 nanometer to 700 nanometers. Phosphotungstic acid are subject to many interference including endogenous compounds like glucose, ascorbic acid, glutathione, and cysteine, and exogenous compounds like acetaminophen, acetyl salicylic acid, and purines. All these compounds reduce phosphotungstic acid and introduce a positive error. Uricase enzyme converts the urates to allantoin. Uricase method, the decrease of absorbance as urate is converted has been measured at wavelengths using from 282 to 292 nanometers. The reaction is measured in either the kinetic or the equilibrium mode. Uricase methods become feasible and popular as a result of the availability of high quality, low cost preparation of bacterial enzyme. In majority of uricase methods, only guanine and xanthine and few other structural analogues of uric acid interfere, that too only in concentration not expected in biological fluids. This method has more sensitivity and specificity compared to phosphotungstic acid. High performance liquid chromatography methods using ion exchange or reverse phase columns are used to separate and quantify uric acid. HPLC methods are specific and fast. Mobile phases are simple and the retention time for uric acid is less than 6 minutes. Dry chemistry systems, devices that utilize uricase in a dry reagent format to measure uric acid also developed. Uric acid calibration is a 2-point calibration, blank and the calibrator. There are 3 levels of QC materials available commercially for daily quality control program. There are 5 levels of linearity materials available commercially. Thank you.